For my pediatrics project, I did it on developmental dysplasia of the hip. So what is DDH? DDH occurs when a baby's hip socket is too shallow to cover the head of the thigh bone, femoral head, to fit properly. So DDH ranges in severity. Some babies have minor looseness in one or both of their hip joints. For other babies, the ball easily comes completely out of the socket. So here's a picture of the anatomy. So there's the hip socket, the joint, the cartilage, the bone, and the femur going into the hip socket. Okay, so some common signs and symptoms of hip dysplasia in babies. So many babies with DDH are diagnosed during their first few months of life. Common symptoms of infants include the leg on the side of the affected hip, which may be shorter. The folds of the skin of the thigh or buttocks may appear uneven. There may be a popping sensation with movement of the hip. And then I've also included here mnemonic, which is for the developmental signs and symptoms. So malformation of the hip due to imperfect development of the femoral head. They do the Ortolani sign when the infant's spine and knees are flexed and the hips are adducted, and a click is heard or felt. So there it shows how that procedure is done. So asymmetrical gluteal and thigh folds, and then it shows the affected side, which is a shortened leg. Next, the causes of hip dysplasia in babies. The exact cause is really unknown, but doctors believe that several factors may increase these risks. So a family history of DDH in a parent, or maybe a close relative, gender. So girls are 2 to 4 times more likely to have this condition. Firstborn babies who fit the uterus is tighter than their in later babies, breech position during pregnancy, and tight swaddling the legs with legs extended. So here's just a description. Breech position is where babies whose bottoms are below the heads while their mother is pregnant with them often end up in one or both legs extended in particularly straight position rather than folded in a fetal position. Unfortunately, this position can prevent a developing baby's hip socket from developing properly. Again, tight swaddling, wrapping of a baby's legs in a straight position may interfere with the healthy development of the joint. If you swaddle the baby, you can wrap up their arms and torso snugly, but be sure to leave room for their legs to bend and move. Okay, so non-surgical treatment for hip dysplasia. They use the device, which is a restorative device called the Pavlik harness for correcting abnormality. So this device is used in babies younger than 6 months. The baby needs to wear the harness all day for the first 6 to 8 weeks, and then for 12 hours a day for the next 6 weeks. Is it important to have regular checkups? Once the treatment ends, the doctor performs x-rays and ultrasounds to check the hip placement for the patient. It is possible to cure DDH with the Pavlik harness, but in some cases, hip continues to be dislocated even after treatment. So over here to the right, there's a picture of the Pavlik harness. The baby's legs are abducted there, and they are placed in the harness. Okay, so surgical treatment will include, they have the most commonly casting is used as a spica cast, and this is what the child here to the right is in a spica cast. This treatment is often used if the fail of the Pavlik device does not work. And the hip is manually restored in its normal position during this surgery. This common procedure is known as the closed reduction. Okay, and then last but not least, we have some nursing interventions and rationale. So assess the muscle strength, bone, and ability to move and actively level and performing ADLs. The rationale would be to provide data about the condition and function of the musculoskeletal system. You want to assess the sensory function, which provides data again, conditions for treatment, and the effect of mobility. Provide and apply harness splint. The rationale is the anatomy and the support of mobility. Keep the body alignment during the bed. Do not position changes. And then rationale would be compliant with the program to maintain mobility. And then we have patient teaching, which is just to teach the parents how to use the mobility device. And that's it.